Accordingly, I would like to get this seminar kicked off. It is, again, like I said, my honor to do it. I would like to thank Dr. Ali Odo, the president of the World Society of Arrhythmias, for his work in getting this seminar started, the board of the World Society for putting this together, and I'd like to also thank Medtronic as a corporate sponsor for providing an unrestricted grant for us to make this come together, and also Magnum Opus, who has been kind enough to put this series together. For those who are not able to attend, then those of you who are attending, please tell your colleagues to go to the WSA website and you'll be able to download and listen to the session at this time. This particular program is focused on obstacles related to pacing and venoplasty and lead extraction, things which are very important techniques to be able to master. Having made the introduction, I'd like to hand it off to my co-moderator, Dr. Deepak Padmanabhan, who will introduce the speaker, and then we'll go from there. Deepak?
Thank you, Dr. Deering. That was a very thorough and in-depth introduction to this entire effort that has been done by the World Society of Arrhythmias. I now proceed to introduce our speaker for today, Dr. Danish Kella, who I've had the pleasure of knowing for the last 10 years. Apart from being a great friend, he currently is an assistant professor of medicine in the heart rhythm department at the Mayo Clinic. Less said the better about him in terms of his academic achievements. It basically would fill up the entire seminar. I look forward to hearing from him on this extremely important topic, and one which he does a fair number of and has a great insight into. So over to you, Dr. Danish. We look forward to hearing from you. Please add in your questions into the chat box and we shall answer them at the end of this talk. Over to you, Danish.
Hello, everyone. Thank you for the opportunity to present today. Thank you to World Society of Arrhythmia and my moderators, Dr. Deering and Dr. Padmanabhan. So the topic that I've been tasked to discuss is obstacles in pacing. So focus on venous stenosis when we're trying to put in new pacemaker, new devices, new transvenous leads, and how we can overcome with emphasis on venoplasty, and then we'll go over somewhat about lead extraction. So I have nothing relevant to disclose in relationship to this presentation. So as part of this talk, what I want to go over is define what this venous stenosis lead related venous obstruction is about, what is its clinical significance, particularly when it comes to putting new transvenous leads, and go over some therapeutic options with emphasis on venoplasty, use a case to discuss how this is done, and then summarize outcomes, complications, and how it compares to other techniques that we'll discuss, and come up with some practical recommendations on when to consider venoplasty or something else when you encounter venous obstruction. So ever since the first pacemaker was built in 1950s, the number of devices that we have been implanting in US, all over the world, have steadily increased over time. This is data out of Switzerland. It's very similar what we see all over the world. And not just pacemakers, other devices that come into play to help patients with heart failure, mitigate risk of sudden death, defibrillators. Now, with all these devices, the common to them is, in most of them, is the presence of this lead, transvenous leads. The transvenous leads work really well in delivering the stimulus that we want to go to the heart and record what the heart is doing, so sensing and pacing. But it is a foreign thing that's going in the body, and any foreign thing that goes in the body doesn't bode well. So what happens to the lead is in the vein, thrombus can form, and the lead itself will elicit this foreign body reaction. So all the immune cells come and try to ward it off. So they create essentially at the end a fibrous capsule around it. Now, this is good if you are a bacteria and helps the body fight against it, but if it is a lead, it creates problems, because this fibrous tissue will start to encapsulate the lead over time. So these autopsy pictures show you how what it does to the lead is that it starts to incorporate itself in the vessel wall, superior vena cava, entangles itself with the heart valves in the heart itself, not only to the heart wall, the vessel wall that it tends to stick the lead onto, to other leads too. And then over time, this fibrosis can make the lead make the vein go smaller, so stenosis. So how common this is? So 50% or more vessel narrowing when it has been looked in studies. Most of them report, like if you do a venogram or some sort of study in all these patients, about 30% of patients do have the stenosis. Complete occlusion, less common, about 10%. And typically where it happens is where the lead is entering the blood vessel near the axillary subclavian innominate vein junction to the SVC. It's very rare to see it isolated in the SVC, about 1% of the cases. So does it really matter, this lead-related venous stenosis? The good thing is when you look at patients with lead-related venous stenosis, the patients that have symptoms, so arm swelling, headaches, face swelling, and things like that, is only about 5% of all the cases with leads. Where it matters is in something like this. So this is a patient not too long ago that I was asked to help with. So one of my partners asked me in the 66 male with CCTGA who had a dual chamber ICD implanted 3 years prior to presentation and had frequent apical pacing. He had underwent a PVC ablation. His systemic ventricle, the right ventricle EF was low, 30%. And I was asked if I could help with implanting a cardiac resynchronization therapy. So I was just trying to figure out where the lead will go, where is the left bundle, right bundle, where it's going to be the corny sinus. But as soon as I got vascular access and through the small sheath using ultrasound that I had placed, I injected contrast because I couldn't get my J wire in to get the sheath in. This is what I see. So the contrast goes up till here, then you got these dense collaterals, and really there's not a lot of contrast going beyond this area. So this is your lead-related venous stenosis. And this is something that we often encounter in the lab when we're trying to put new leads or upgrading devices. And as most of you who have been in EP practice for long know, that the device that you implant at the beginning, the indication for it changes over time. Patients might develop progressive heart failure, they may have new left bundle branch block, and they need cardiac resynchronization therapy, so addition of LV lead. Or over time, their rhythmic risk changes. Now they need something to mitigate sudden death, and you have to put an ICD in patients who had pacemaker. Lifestyle changes over time, patient ages, the sinus node is not working. Patients who had single chamber ICD now need dual chamber upgrade. And then let's not forget, these transvenous leads do not last you for lifetime. Over time, the leads can fail and then you need new leads or recalled. If you look at some of the numbers that have been published in literature, pacemaker to ICD conversion rate about 5%, and about 30% of the cardiac resynchronization therapies that are being implanted, the new LV lead being implanted, is part of an upgrade. This data out of Utah, if you look at one center, 10-year lead failure rate, pacemaker about 8%, ICD leads 11%. And if you have a recall lead, Sprint, Fidelis, Reata, about 21 to 22%. And this data out of replaced registry, when they looked at lead damage after generator change, up to 2% in those patients. So it's not often that these leads fail and then you need to put a new lead in these patients. And so how do you manage this? So if you think about venous stenosis leads, how do you manage it? One is that, like, if you have a lead that has failed or you don't need it, you can potentially take it out and put a new one in. We'll discuss this a bit. You can go to the other side, to the other axillary subclavian vein or cephalic vein, put the lead in, get it down to the heart, and then tunnel it across, or go to some other site and then tunnel it to your existing pocket. Consider opening up the vein, and then we will discuss some other strategies, just not go with transvenous leads anymore or get access somewhere else. So of all these things, if you think about venoplasty, this is not something new. So venoplasty, we're trying to open up the vein. If you think about it, this is what is part of our core cardiology training. We have been doing it for decades. This picture is of the patient Laura Shaw, who underwent first intentional percutaneous angioplasty. So her superficial femoral artery on the left side was opened out due to gangrene, and she did well from it. So not something new that we are doing, something that we have been doing for many years. And it's not just in the arteries, it's not just in the coronary arteries or peripheral arteries. It has been done in the veins in other scenarios too. So patients, our IR colleagues often do it for patients with hemodialysis, who have got SVC obstruction, who have got other peripheral venous disease. And so the question becomes is how do you do a venoplasty? So important when you're trying to do a venoplasty is to do a good contrast injection to get a sense of what the stenosis looks like. So this is a time if you're doing it peripherally, so through an IV, put in the ipsilateral arm, trying to inject good amount of contrast. So 20 cc's, not 10 cc's, not 5 cc's. Because you give 5 cc, 10 cc diluted, you don't see something, and then you end up giving more contrast later on. So what you should have been 20 to begin with becomes 30. And then not just doing a peripheral venogram, like injecting it through the IV, is looking up and even bringing a microcatheter up if you need, and injecting to really see where the stenosis is, because it's important whether you have a small channel that is going through or it is complete occlusion, because that might change your strategy, how you try to open up the vein. And then once you have identified it, once you get access, trying to maneuver a wire down. So using a hydrophilic wire, taking your time to gradually maneuver, trying to find the right channel to go through to take it down is very important. This is something that requires patience and very important to know whether you're in the true lumen or not. So once you get your wire down, trying to push it down either to the IVC, ideally, so you have a nice rail, or trying to go into the right ventricle to the pulmonary artery. Once you have the wire in, then looking at multiple views. So looking at RAO and LAO, making sure that it is trying to follow the other lead. So that is within the lumen, not in a collateral, not in some unwanted space that may result in complication. And then again, getting familiar with balloons and end deflators, something that we typically go through in our training. It's part of general cardiology. Again, getting familiar with what an end deflator, like a device to blow up the balloon, looks like, how it works, and then getting familiar with some of the balloons that are used in peripheral arterial disease. So in our practice, we typically use this Evercross, but there are other compliant and non-compliant long balloons that you can use, typically 4 to 8 millimeter, more so towards the 8 millimeter range that you would be using. And before you put the balloon over the wire, the hydrophilic wire that you might use might be not stiff enough to allow you to push through a balloon. Consider exchanging it over a catheter with a stiff wire such as M-Plus or M-Plus extra stiff wire. Once you have the wire in, you have put the balloon in. The way we do it is we inflate the balloon in the right atrium and then gradually pull it back up to your pocket, to your entry site. And the reason you're doing it is, for one, is you identify where the stenosis is going to be. Second, it's another confirmation that you're in the right area. So if the balloon and the leads move together, then you're in the right area, you're in the right lumen, you're not in collateral, you're not in some unwanted space. Once you have it in the right area, then you deflate and gradually start to inflate it. We do it serially from the right atrium all the way up to your entry site, or where you think the stenosis is. Because sometimes you may see the stenosis starting here, but it is long. So you want to inflate it all the way back. So you keep inflating it serially, pulling it back, just like you do it in any other venoplasty or angioplasty technique. And then how far you do inflate it? You inflate it till you start to see this wasting go away. So typically going up to nominal pressure, that will get you to the size of the balloon that is intended. And if it is not working, then going up to the raised burst pressure that is for the balloon. And let's say if this doesn't work, it's not opening up the vein, the waste is not eliminated as we saw here, then consider escalating to a more non-compliant balloon, so Atlas or something that's reinforced with Kevlar, ultra-high burst pressure balloons. And once the vein is open, I mean, it's such a gratifying thing, like you started with something tough, but let's not forget what we intended to go for is to focus on what to do, what we were there for, to put a new transvenous lead. So in this patient that I just presented to you, we ended up putting in a left bundle area, or in this case, a deep septal lead to help resynchronize the heart. Now, question comes up is where to get venous access. Like, should it be in the pocket, or should it be more further away in the brachial vein to do this? And the way I think about it is, and what we have done within practice with our colleagues in interventional radiology, is sometimes our interventional cardiology colleagues is that depending on the site of stenosis. So if it is something like this, like very tight lesion, like where you don't clearly see a channel, it's more towards the axillary subclavian junction, further away from the nominate SVC, then starting to get a brachial axis makes more sense. Sometimes you can get away with having more axillary. The key here is that what you want is to have some room to maneuver the wire and then to be able to put sheaths to guiding catheters if needed to do it. So if I get access here very close to, it's going to be very hard for me to maneuver the wire or maneuver my sheaths to get across it. But if I'm further away, then I would have what is sort of a way I think of as a runway to get my wires maneuvered down this lesion. And the other thing is using support catheters. We often, and I would say like in my practice, at least I always use this K2 catheter when I'm trying to negotiate a lesion like this because it's very helpful, provides you support. And again, very important with this is that like you take your time. It's not a quick thing. You take your time. You gradually maneuver the wire down. It's very important that you get it in the right area, the lumen where the leads are. Complications. So overall complication rate is very low with this. So generally, if you look at case series, even what we have presented and published, and my personal experience has been balloon rupture. So sometimes these lesions are calcified or you go a little too aggressive with the balloon, it will burst, but it generally has no clinical consequence. Every now and then, once you have done with venogram or during the venogram, if you inject contrast, you will see contrast going outside, staining around the site of stenosis or around the length of the vein. This is typically self-limited due to low venous pressure, usually well tolerated, has no clinical consequence. And then pocket hematoma, excess site bleeding. So when you are doing your venoplasty, once you have put your sheath in, having a purse string suture there to control the bleeding, because like you're opening up a stenosis, the back pressure is high, you're going to have more bleeding than usually you do if the vein was open. Uncommon rare complications. Usually in device-based venoplasty series haven't been reported, but just from experience with other things, opening up the SVC in hemodialysis cases and other venoplasties, uh, anything serious, procedure-related mortality, need for emergent surgical intervention, hemodynamic instability, SVC rupture, again with device-based registry hasn't been reported, but like you should always be on watch out for. Again, uncommon to see pulmonary embolism or significant venous rupture, lead damage or dislodgement in my experience of what we had reported or anything that I reviewed hasn't been reported in setting of venoplasty. Success rate in our experience and generally, if you look at the literature, 95%. So it's something that can likely result in opening up the vein. Where do you fail? So there are certain things that you can predict. If you look back at the cases that have a failure, is some of them are lesion related. So you have a very long total occlusion. This has been chronically occluded for many, many years. Long segment of fibrosis, which where you try to balloon, you could escalate the balloons, you get bigger balloons, you get stiffer balloons, but it just wouldn't open. Like the fibrosis is so much that it recoils. Then lead related, multiple or abandoned leads can result in long dwell times, and the vein has been subject to more trauma over time. So maybe a patient had central line before, maybe they had multiple leads change out before. Those are the ones that are going to be hard to open. And then small tortuous venous anatomy. And then if you're not familiar with the technique, then that can also be a potential reason for failure. So how do you overcome some of these challenging chronic occlusions, like very tight lesions? It just depends on your experience and experience of other partners around you. So if you have interventional radiology colleagues or interventional cardiology colleagues that can assist you. So one thing that you can consider doing is using even a smaller wire, so coronary wire, so 014 wire to negotiate the stenosis across the lesion. And then first dilate with smaller balloons. So monorail balloons, long balloons, like 2 millimeter, 3 millimeter, 4 millimeter, gradually going up on the size to open up, then exchanging it for a bigger wire and then a bigger balloon, your 4 to 8 millimeter over the wire balloon. Venous stenosis in other areas has been crossed using RF wires. You can potentially consider it using it, but This is something you should do with a person who has experience. So it involves using a radio frequency wire, figuring out where the stenosis is, where the two ends of the vein are, and then once you cross the stenosis, snaring the wire to come across, and then again going over the whole balloon before you put your sheath and your lead in. Intravenous lithotripsy, so using ultrasound waves to shock open lesions, have been well reported and approved in peripheral arterial disease, recently in coronary artery disease. And there has been a single report describing the use for venoplasty to put a lead in out of Mayo Clinic, Rochester. This is an approach that I will leave here and for you to review, and it's in a curriculum or in your slide deck that I will leave, is like how you think about it, how approach it. The key is like understanding where the stenosis is to make a decision whether you should go further in the brachial vein or in the pocket. Then trying to get a local venogram, because like getting as close up to the vein, the stenosis site in the vein as, and then injecting contrast to see, and whether you have subtotal occlusion, so you have a small channel that you can cross, or total occlusion. Your subtotal occlusion, starting with an 035 wire, a hydrophilic wire, then exchanging it for stiff, then using your wire, the big balloons 4 to 8 millimeter, opening it up and getting the job done. But if you can't cross it, or it is total occlusion, then maybe going to a coronary wire, gradually dilating it, and then going over to your bigger balloon to open it, and then getting your lead in that you intended to. So let's say if it is not venoplasty, what else can you do? So one of the things is lead extraction, right? Like you just take the lead out. But the problem with lead extraction in these cases, so for example, this case where you have venous obstruction, you have an ICD lead, there's an old patient's lead that was abandoned and we were trying to upgrade it, you can consider removing it. But as I had mentioned to you earlier, that over time, when the leads stay in the body has this very strong fibrous reaction to it, foreign body reaction to it, that results in fibrosis, and this lead getting attached to the veins over time, particularly the superior vena cava. Sometimes these get also calcified, as you can see here, like a chunk of calcium moving with the leads. And all that makes it very hard to remove it. So you can't just pull it out of the body whenever you want it. Over time, if the lead has been with the patient for long enough, you need specialized tools. So these involve locking stylets, snares to grab the lead from the femoral vasculature, and then use of specialized tools, laser sheets, cutting tools, mechanical extraction tools to try to carefully dissect these leads out to make room for a new lead. And one of the big fears when we're trying to do it is when you bring your laser sheet, mechanical sheath to try to free this lead up, as you can damage the superior vena cava. And if this not recognized and treated immediately, patients can die within minutes. And risk of major complication, including this and others, anything serious, is about 1 to 2%. So it's not trivial in these extractions of leads that have been in the body for long periods of time. You can have some idea which one are going to be the high risk one by looking at some of these risk factors: female patients, low BMI, ICD leads, multiple leads that patients had, and overall dwell time, if you combine them, is more than 10 years, dual coil ICD leads. These are the ones that are going to be high risk to remove. So generally, when we are doing extraction, and most centers around the world, when they do these high risk extractions, they do it in a way that they are able to bring in a cardiothoracic surgeon immediately if the patient has SVC rupture, crack the chest open and repair it. So this involves a lot of logistics, right? Like you have to have everything available. And when you're trying to take a lead out just to put new one in, it adds this risk of extraction itself, more cost, all these tools that I showed you add more cost to things, and then you need to have skills to be able to do it. And sometimes you come across these venous stenosis in your EP lab where you don't have cardiothoracic surgeon, maybe in a place where you don't have cardiothoracic surgery backup at all immediately available. So that puts you in a bind. You cannot do it on the fly, and then you have to either reschedule and think of something else that we discussed, consider venoplasty. What it may be helpful is like this up front, and you have a younger patient where it might not be wise to leave a lead behind. So if you're planning to abandon or take it out, maybe considering removing the lead in that patient you were thinking of abandoning. or you know that patient will be left with multiple leads, more than 4 leads in one side or more than 5 leads going through the superior vena cava. This is a class 2A indication to remove the lead. When I consider it, and when you should consider it, that they are favorable lead and patient characteristics, or there's a pressing indication to remove the lead. And just to give you an example, like this is not an easy thing. Even this is an 8-year-old pacing lead. So this is a 66 male with renal transplant, had complete heart block, and high RV threshold. And he had come in for Gen-Change, and he was planned to undergo RV lead revision because the thresholds were high. It was eating through his battery. So we discussed and elected to remove it. He had venous obstructions. So just to give you an idea how difficult it is, like, so we're starting with this laser sheath first, can't get it through. Then we switch to this another cutting tool, an evolution sheath. This didn't work, didn't get the job done. We switched to another sheath here. So this is a tight rail sheath, again, a cutting sheath, mechanical sheath, still not making any progress. Then going to a bigger sheath. Then finally we were able to get it down and eventually remove the lead, retain access, and then ended up putting this left bundle area pacing lead. So again, it is not easy. That's why, I mean, I feel like if you don't have a pressing need to remove the lead, consider venoplasty first. Where extraction would be preferred, if there are leads that are not needed and the patient prefers or their favorable characteristics or they're younger, that's where I would say like daring to take the leads out. And it's always a shared decision making. I mean, we typically sit down with the patient and go over the pros and cons of removing a lead before we embark. And again, the key here is when I think of venoplasty versus lead extraction, venoplasty is something I can potentially do even without knowing about the stenosis. If, let's say, I didn't know about it, but when it comes to lead extraction, if I see a stenosis and if I don't have the right backup or the right personnel or right equipment available, I cannot do it on the fly. So let's say, I mean, we talked about these top 2 options, like, I mean, you don't have cardiothoracic surgery available, you don't know how to extract leads, or venoplasty didn't work, or you haven't had any experience with, you don't have a colleague, what else can you do? So one thing you can do is when you have a very tight stenosis, either you've tried venoplasty or you don't have experience with, is you can always use the other side vein to put the lead in, then tunnel it across underneath the subcutaneous tissue and connect to your battery. The downside with this, the big one, is that when you do this, like think about like you're using the other vein too. So something that led to the stenosis here can also lead to stenosis here. So let's say in the future, if you need this vein for anything else, you're losing it. The other big one is like if this is closed and patient is asymptomatic, and you end up potentially closing this because of the new lead, and now they have bilateral stenosis, maybe now they will become symptomatic. You don't only have to use the other side. There have been reports where you can just tunnel it across through the internal jugular vein, then tunnel it across over the clavicle, and then connect it to your battery. So that's ipsilateral side access and tunneling that you can consider as well. When we looked at our experience many years ago, Deepak and I looked at is when we were co-fellows, is that the big thing with tunneling is that your acute procedural complications are higher and mostly are driven by bleeding complications because as we know, more and more of our patients are on anticoagulation and more time, often we are not stopping it. And when you tunnel it, you create this tunnel that can result in more hematoma. And not only that, like if you think about it, if you're trying to get access on one side, then you're trying again on the other, you're risking hemothorax and pneumothorax and other things as well. Other thing that have been reported in literature before venoplasty became more and more used is trying to get access even further distal to the site of obstruction. So trying to stick near the junction of innominate and SVC further away from your stenosis. As you can imagine, you're starting to lose your protection from the rib that you get, like higher risk of pneumothorax, in my opinion. And this is less and less reported now. This is like I would say an older technique. can you predict when you're going to encounter lead-related venous obstruction? So there are things that you can look, risk factors that patient might have. So the big ones, like if you think about it, the gist of this is that if you have multiple leads, patient has gone multiple procedures, there's been more trauma to the vein, you're more likely to encounter fibrosis and stenosis. And particularly patients who have end-stage renal disease, who have dialysis catheters and calcifying and risk for calcification of the stenosis. And on physical exam, like even before the patient comes in, when you're in consenting or in your clinic, when you see them, if you see large collateral veins on the chest, something similar to this, then you should start thinking of that patient might have venous stenosis. And then if you're thinking of it and you want to plan it ahead, like someone high risk, so for example, this patient, so he has got end-stage renal disease, had multiple dialysis access, multiple catheters placed over time, and he has a right side device. There was a question about putting a left bundle area pacing lead. Doing a CT venogram, cross-sectional imaging is very helpful. Ultrasound, I don't think so has much value, but CT venogram has a lot of value here. It can give you the site of stenosis, help you plan. So here, if you look at the cross-sectional imaging, these are the key images here that you have. The innominate vein, the axillary vein come in, then a big collateral. You can see the leads coming down the innominate into the SVC, but you don't see any contrast going. So he has got like complete occlusion of the brachiocephalic or innominate vein on the right side from these leads and prior trauma to the vein from axis. So how do I choose between all these options, or how you should think about it? Venoplasty, this is safe and effective and typically should be our first choice when we're trying to open up an obstruction to trying to place a transvenous lead in the vein. Familiarity or a cooperator, so either you have experience with it or you have a cooperator who helps build that experience. This is not very difficult technique to learn. If you think about it as an extension of our existing tools, this is something that we have been training before, and then it involves using wires, catheters that we are already familiar with. And going over some techniques like that we talked about, using a CTO wire or CTO-like wires and tools, or using radio frequency wires, all those, if you have a cooperator who does it with something else, like from interventional radiology or interventional cardiology, then you can start learning and incorporate that too. When it comes to lead extraction, when I think about it is when the lead is not needed and it has favorable characteristics. That means like either the patient is young or the lead is not too old, and then considering removing it to make room for the new one. And should have experience, you'd have all the resources, cardiothoracic surgery backup, all the tools that we were talking about. When it comes to tunneling, I would say like this would be my last, like when we have failed venoplasty, there are no other options, or I cannot go to lead extraction because the patient is old or may not do well with another procedure. That's when I would consider it. And let's remember, like, what caused the problem, the stenosis, is these transvenous leads, right? Like if there is an opportunity, an option to avoid the leads in the future, maybe considering a subcutaneous ICD in that patient, a leadless pacemaker, or even epicardial leads. So think about those when you encounter venous stenosis in these patients. So take home points for that. Like this is common in about 30% of the patients, and when it becomes relevant is when you're trying to put new leads in. Most of them are asymptomatic. That's good. We talked about venoplasty as a first line, consider lead extraction and contralateral access and tunneling that we discussed. Then when you're doing venoplasty, do a good peripheral venogram. Think about how you're going to escalate the wire, and then balloon dilation has high success rate, overall low complication rate. And then plan ahead, like physical exam, talking to the patient, the risk factors. You can plan ahead and maybe getting a CT venogram to help that. And then overall try to minimize the lead burden if you can, and choose the least invasive effective strategy. I want to thank the World Society of Arrhythmia for arranging this, and my moderators, Dr. Deering and Padmanabhan. And I'm happy to take any questions.
First of all, Dinesh, on behalf of Deepak and the World Society of Arrhythmias, I want to thank you for this very logical and organized presentation in which you very nicely presented all of the different options, the pros and cons, and the expertise that is needed to deal with them. Again, if anyone has any questions, please feel free to put them into the chat and we'll, advance them forward. Deepak, do you want to start off with a question for our colleague, Dr. Kella?
Absolutely. Dinesh, thank you for doing this. That was a tour de force. Very, very practical, helpful points. And I'm sure everybody who has access to this is going to be better off for having listened to it. So let me just start off the discussion by asking you, is there a specific access needle or wire that you want to start off using when you've already diagnosed the obstruction? You've done the venogram. Is there anything specific that you would say, I'm going to use this needle, I'm going to use that wire, and so on? How do you take it?
So that's a great question. I most of the time, like I would say like not even just venous obstruction, just in general, I prefer to use a micropuncture kit or a 4 French needle. So it has its benefits. Generally, I personally try to get ultrasound guided access, whether it be brachial or in the pocket. When we are doing brachial, I usually involve one of my interventional radiology colleagues as well, because when they have a little more experience with that than we do. And that would be the big thing. And starting with a wire, I would say starting with a hydrophilic wire, so like a glide wire, something that is hydrophilic, and maybe starting with an 035 wire would be the way to go. And if it is not working, then going down in caliber to trying to go to like your coronary wire if needed, and going from there.
Dinesh, you talked very nicely about all of the different options of venoplasty extraction and then, using, tunneling or using different types of leads. Those are all components that we have in our toolbox. You mentioned venoplasty as an option, the ease with which you've been able to develop expertise. For many of the people who will be watching this particular seminar, they don't have the long-standing experience and training in a cardiac or a cardiac electrophysiology fellowship. So if you were talking to someone in an area where they haven't done this before, what do you think is requisite for them to get comfortable with this and to be able to accomplish it in a, reasonable way? Do they have to go somewhere and spend some time with someone? Can they do it on themselves with someone online they can communicate with? What would you recommend for venoplasty learning?
I think like if they talk to their colleagues in interventional radiology, if it is possible, it's something that I think they would be very helpful, because I think they do it a lot in other scenarios. They can come in, maybe scrub in with the first two, maybe 5 cases or something, and then they pick up the techniques from there. And starting with anything, like we talk about lead extraction, VT ablation, anything complex that we do, starting with something that is a bit on the easier side, then going over more the challenging cases, and always trying to bring in a cooperator is what I would suggest. As far as I would say, like it's always better to observe a case or have someone who has done it in the room with you when you're trying to do it at the first time. And so that would be my suggestion.
Thank you.
Dinesh, a lot of times when we use these hydrophilic wires, we have the ability, and it's a acquired ability, to get into channels where we don't want to get into. Or you move the wire that goes in and it goes into a location where you've not realized that you've created a false lumen, a false passage. You shoot and die. Sometimes you see some collection. Does that deter you from proceeding with the case, or is it something that you say, I don't really care about this, I will still go ahead? How do you manage it, both intra-op, post-op? How do you go do that?
Yeah. So generally, like if you even are in a collateral, or maybe you have like some contrast extravasation that makes you feel that like maybe I perforated something, it is a low pressure area. It is tolerated very well. In our experience, generally we have continued with it, particularly if you're very proximal, like you're not close to the superior vena cava, that we have continued. But that's where I cannot stress enough is once you have the wire in and you think like you're in the right area, looking at in multiple views, or even when you're trying to navigate to look in multiple views. And the good thing is you're going to have a lead there for you to know like, okay, all right, this is the channel, this is the area that I need to follow. And if you're going off in certain views, again, doing a small contrast injection to see like, am I in a collateral or not would be important.
And you're not too worried. Suppose you've inflated the balloon into one of them, you've gotten a small localized hematoma. It's perfectly okay to continue and try and do it again, right?
So if you have a hematoma like from a balloon inflation, you have to think about it how is the wire that you're missing the first part, like the wire is in the odd position. So it's very important like before you inflate the balloon is that you have your wire through all the way into the IVC RA or in the RBPA so that you have known like you're in the heart. And then look, if after that you have a hematoma, generally we don't inject contrast to know like if there's contrast extravasation afterwards if you have it. Once you put the sheath in, generally we don't inject contrast. But if you have a small hematoma or a small contrast extravasation that you need, you can continue to monitor the pressure. I would say like by this time, if you have your sheath in, like to continue with the procedure, not to abort at this point.
Yeah. Yeah.
But like to bring to your point, okay, means things haven't been reported in device related venoplasty, but these have been reported elsewhere in negotiating venous stenosis. So always think about monitoring the patient safety first. If anything is not going right, then stopping, talking to your anesthesia or your colleagues around you to see if we can do any testing to see if there's blood loss and then manage accordingly.
Dinesh, one of the other questions that I would have is, when you see an obstruction and you approach, do a venoplasty to overcome it, but you've got indwelling leads. Let's say you have, two leads or three leads. Now you're adding an additional lead. You already had a stenosis develop. Now you're compromising the amount of available flow. You're potentially setting yourself up for another problem and maybe a more difficult thing downstream in terms of lead extraction when you have multiple leads adherent to each other, et cetera. So, are there certain considerations that you take into account when you're thinking about, gee, I can do a venoplasty successfully, but the long-term consequences might outweigh the short-term benefits? How do you put that in the whole picture when you're trying to make a decision in concert with the patient?
Yeah. So that's an excellent question. So if I have more than 4 leads on the ipsilateral side, so let's say I'm going up to 5 leads or superior vena cava will end up 6 leads, that generally we don't go. We try to take the lead out. And even before that, like if there is a lead that we're going to leave behind, I try to have good justification for it. So if someone elderly or somewhere the lead has been in for many years and the patient is not willing to consider risk, or as an operator, I don't feel it's worth the risk trying to take it out. And when you're running into a situation that you're mentioning that is like it's lead number 4 from, let's say, the left brachiocephalic, left innominate, left axillary vein, and if the patient has venous stenosis, if you think about it, if they're asymptomatic to begin with, it's likely the collaterals are there. And once you open this venoplasty, you put the lead in, if it was total occlusion, it's going to close again. Generally, they won't develop symptoms down the road.
What's your experience with cutting balloons? I mean, how have you figured those out?
So personally, we haven't used cutting balloons in this. There is this some consideration on my part, like would that damage the lead, like the insulation or anything? Again, anyone who has done it hasn't reported any damage to the leads. And when you say damage to leads, it's something that you can see on your device interrogation, right? Like the impedance changing or the pacing numbers or sensing numbers going off over time. What has been reported in one case report is intravenous lithotripsy, which I think looks attractive in calcified lesions. Uh, uh, yeah.
One other question is, a lot of times when you're trying to do this, you're basically also forget the venoplasty or the venous occlusion. How do you deal with the fibrotic tissue while just upgrading to a different lead, add on to a different lead? Because one of the most common things we deal with, especially if there is a pre-existing device, is the fact that the pocket is already formed. You have fibrous tissue there. So would you, at every chance that you get to open a pocket, strip the fibrotic tissue away from there so that you are in a much better state later on? Or would you only wait if you have to take venous access again to kind of do that kind of a procedure?
So generally, like if you have fibrotic tissue in the pocket, trying to get venous access either through it or making small dissection to get to the muscle to do it, I think either way is fine. I don't think so. It makes a difference to your venous stenosis. Now, if you have venous stenosis and fibrotic tissue too, again, the key is the site of your access, because what you want is some area to be able to easily maneuver a wire or your supporting catheter. So if it is very proximal, I would still go into brachial, get the access, inflate the vein, and then get access. But if it is more distal, like more towards the innominate brachiocephalic SVC junction, maybe getting into axillary and then negotiating it from there. I think so it will have more bearing on the fibrotic capsule, how I do venoplasty.
That's true, but would you recommend prophylactic fibrotic tissue removal at every chance you get to open the pocket so that any future accesses into the vein or performing venoplasty would become easier? Is that
No,
something that you suggest?
no, I think, I mean, if you look at the literature behind it, like prophylactically removing the capsule just in setting of generator change didn't help. Like if anything, you have more bleeding complications with it.
One,
Dinesh,
go
oh
ahead,
no,
doctor.
Deepak, okay, thanks. Dinesh, at the end of your presentation, you talked about, one option being the use of leadless pacing. Leadless pacing is becoming much more frequently employed. We now have devices that can pace both in the right ventricle and the right atrium, and we're, beginning to develop programs that can, achieve resynchronization. So when you're looking at that today and you have all those options, and maybe you don't have as much experience with venoplasty as you would like, how do you look at it? Again, in someone who has LV systolic dysfunction, you run the risk of not being able to have left bundle area pacing or left bundle branch pacing and exacerbating the cardiomyopathy. Otherwise, you don't have that risk up front, but you may develop it downstream. So when you're looking at that option where leadless pacing is a rather simple thing to do and someone doesn't have experience, should they get that experience so they can do venoplasty and try to put in a lead, or should we be moving more towards capping those leads, leaving them alone, and moving to leadless pacing? How do you approach it, especially in areas around the world where people may not have as many resources as others do in big centers like yours?
Right. I th I think if I were to think about the two options, like learning leadless pacemaker venoplasty is still, I would feel, a relatively easier thing to learn. It's just like, I mean, I would say like having one or two cases with someone to get an idea would be helpful. And I think between the two, I would say like you should have both options in your toolkit to do it. And as you just mentioned, like there are still some limitations with this leadless pacemakers. They are there, but they're not perfect. They're not the same as transvenous leads or the sensing or the resynchronization, even between A and B that we get with transvenous leads. And especially like, I mean, when you have these younger patients where you need high heart rates or better AV synchrony or VV synchrony, I think you will not have a lot of leadless options there as of now. I think over time, if you look at the technology, yes, I think the transvenous leads would be something of historical significance as we go forward. But as of now, I would say having venoplasty in your toolkit is important. And yes, I mean, in situations where you're uh, uh, getting into an issue where you can't do it, then considering leadless is very reasonable.
I think that's a very important point that you make there, Dinesh. As clinicians performing these procedures, we have to improve our techniques and keep up with options as they manifest. So being able to do traditional things, learning how to do venoplasty as a rather simple procedure, and being comfortable with leadless pacing and understanding all the pros and cons of each so that in each patient you can make a more informed and appropriate decision, I think is right. I think you gave a very balanced answer to that question. Thank you.
Thank you.
Dinesh, there have been experiences where instead of going antegrade for the venoplasty, people have attempted to do it from the femoral route or so-called inside-out venoplasty. What are your thoughts about that? Do you think that's a much easier way to, once you've diagnosed the venous occlusion, to actually go ahead and tackle it, or would you still go antegrade?
So if you have a subtotal occlusion, so you see a small channel or like a stenosis where it's hard to get your sheath or dilator across, then going antegrade is very, very reasonable. You don't have to come from the femoral vessel to try to open it. If you have a long segment of stenosis, like a tight stenosis where it's going to be hard and like you think that's the best case option, then doing both is reasonable. That's where, again, like when we have done it, we've gotten our interventional radiology colleagues involved. We're more experienced doing it. And that's where, if you think about one of the things that I mentioned is use of radio frequency wire, that's a prerequisite for it. Because what it gives you an idea is that I know the vein stops here on this side, but where does it start again? So if you come from the femoral vessel, inject dye, then you can see both ends. So if you inject simultaneously on both sides, then you can see like this is the area that I'm missing, looking at multiple views, and then targeting going to the other side is helpful. And that also helps you with snaring the wire from the other side, from the femoral, and bringing it down. That gives you a nice rail to cross balloons. Is it important for, or is it necessary for every case? Absolutely not. Like only for certain high risk cases, or not should I should say like more difficult cases where you have total occlusion or chronic occlusion that you are trying to open up.
Is there a specific skill level that you would advise the femoral route towards beginners or experienced people, or do you think it doesn't really matter?
I think experience, I would say like this would not be something for beginners. And when I said femoral, I'm also saying that femoral only for the select difficult cases. The key here is to know like you're back in the vein, like you're from the vein back to the vein, and like you're not in extravascular space and then went back into the vein, because that is something that's where you're running into complications. The one that you had earlier asked, like what if you have a hematoma? That is not a hematoma, that's a vein tear where if you balloon it, then you can have major bleeding.
And I mean, from me, the final question, how do you prevent a venous occlusion from developing?
That's a good, that's a good question. I think, I mean, if you look at some of the retrospective data, I mean, because a lot of our patients on anticoagulation, you would think it will make logical sense that like if they're on anticoagulation, but if you look at the relationship, the preventive effect of it is like it's still weak. The way to prevent venous occlusion is what Tom had just asked, is like maybe we avoid the transvenous leads in the first place. But which is easier said than done, right? Like, I mean, a lot of our devices, a lot of patients still will have the best outcome if we put in transvenous leads and devices.
I'm going
Yeah,
to
that's
make
a
sure.
very good. Go ahead,
I'm,
Deepak. I'm sorry, you're going to say
I'm
something.
No, no worries. I just said I'm going to make sure that we have a reel made out of that last comment by Dr. Kella and keep rolling it out. I'm pretty sure he's going to get a lot of industry sponsorships on that.
Dinesh, one last question from my part. At the beginning of your presentation, you talked about, looking at factors that might indicate that the patient, is likely to have an occluded vessel. What do you think should be basically the approach that a clinician takes? Many times, devices reached end of life or whatever, or they're going to do an upgrade and they just automatically schedule the procedure without thinking about, gee, could this patient have an occlusion and what skill sets do I need or what colleagues do I need to be involved so that the patient gets the best outcome? So if you look at it from that broad perspective, we can finish on that note. What do you think a clinician who's considering a new lead should be doing upfront?
I think, I mean, few things like, I mean, if you're someone very skilled at this and if you're someone that your center has a lot of experience doing it, then at least, I mean, I would still say like getting a good history, physical examination, like anything that we do is important. If you see a lot of collaterals, then at least I always like counsel the patient and in majority of the cases even consent them or I consent them for all my cases for venoplasty as a separate thing. And the other thing I would say is that if you're not fairly experienced or you have some concern and you don't want to open, sorry, if you don't have a lot of experience with venoplasty, then maybe getting a CT venogram to help prepare yourself and the patient might be helpful in it. Should we do it for all cases? I don't think so. Should you do it routinely? I don't think so. But like again, if you're building your experiencing, because like I mean these like chronic occlusions, like total occlusions, which are going to be difficult, and you might not be able to call a colleague on the fly, like then arranging them to be available if needed would be helpful.
Well, Dinesh, I want to thank you very much for, again, putting together a great presentation addressing all of the relevant issues and for answering the questions in a very, very, expert way. I'd like to give you an opportunity to, make some closing remarks on this issue. What are your thoughts? I know you summarized on your, penultimate slide, but are there any particular, considerations you'd like to leave with the listening and watching audience?
I think the big thing is like, I mean, what you had asked as one of the questions is like, I mean, how should we do it? I mean, one thing I would say is like, once you start doing it, and if you are already in interventional electrophysiology and you had some background in interventional cardiology, even like in your fellowship, or you have colleagues next door, this is not a very difficult technique to master, especially in some of these occlusions, which look very tight at the beginning, but you see there's a channel opening and that is not difficult. And you can avoid all these other things, like particularly contralateral access and tunneling. I mean, you can easily avoid that.
I think that's well said. Developing and expanding one's expertise and having an appropriate toolbox. You don't want just a hammer or a saw. You want a toolbox with all of the various tools that can help you get to the point that you want to get to. Well, again, Dr. Kella, Dinesh, I want to thank you very much for taking the time to, spend with us to discuss this issue and to, make me much more knowledgeable about it. And I'm sure that the listening audience will do that. Again, I want to thank my colleagues at the World Society of Arrhythmias, our sponsor Medtronic and Magnum Opus for putting this on. And I encourage anybody who's listening and watching to get your friends and colleagues who are involved in this field to take a look at this. I think you'll come away with a lot of information that will be beneficial in your career. So again, I thank you very much, Dinesh, for joining us. And I'll hand it over to you, Deepak, to close us out.
Thank you, Dr. Deering. That was very well said. Dinesh, once again, thank you so much for doing this. I, as Dr. Deering echoed, did learn a lot. I know now how I can approach a venous occlusion with greater clarity. And I'm sure a lot of my colleagues and students who log in to the World Society of Arrhythmias to listen to this talk would also have the same experience. Thank you once again for doing this. And for the benefit of our listeners, Dr. Kella has gone to the hospital to record this for us at 7 a.m. in the morning. So thank you very much once again, Danish. It's been an absolute pleasure. And I hope we can continue collaborating on this platform in times to come. Thank you once again.
Thank you.